Good afternoon, everyone. Can't hear me? Can we turn this up? I don't know if the microphone, can you hear me? A little bit. Is this better? Is that better? Can you hear me now? Okay, great. Good afternoon, everyone. I'm Christy Eduardo, and I'm co-chair of the Women's Leadership Council Education Committee, along with Liz Sacco. Thank you all for being here for the first lecture of our 2019-2020 lecture series. I know we are all eager to learn from Dr. Gross how to get a proper night's sleep. But first, we have a few items of business that we'd like to take care of. One is to extend a big thank you to the Northbridge Insurance Agency of Concord, which sponsors our lecture series every year. Another is to remind you to silence your phones and electronics during the lecture. And lastly, most importantly, is to introduce you to our ambitious $2 million fundraising initiative, the Women's Leadership Council Hospice Comfort Care Fund. We are raising money to help Lahey Hospital Medical Center patients in need afford supplemental nursing and hospice care at the end of life. The palliative care and social work teams recommend modest grants from the fund when families need to help pay for care in non-hospital settings, in their home, in hospice, or in long-term care facilities. Even one case, an ambulance. Let me show you a film about one of our patients and his dying wish. Hint, it involves an ambulance.
The spotlight on Bill Garland was a bit intimidating.
Just bear with me, I'm a little nervous.
But in this moment last year, at Pathways Gathering Space on Martha's Vineyard, he put his nerves aside to share a story that was important to him. A story ripped from the pages of his Vietnam War diary.
The name of my book is Da Nang Postscripts, and it's sort of like the result of my life or my fictional character as a result of post-traumatic stress disorder, of living through the war and then the aftermath of the war.
Writing the book was cathartic for Bill.
I enjoyed writing. I got rid of a lot of things that were caught up inside me that the writing allowed me to express. So it's been a blessing.
Reading his book to a packed room, people hanging on his every word and in awe of his bravery, meant even more to him.
On the positive side, I must confess that my mental survival has been better than most. The generic form of insanity was rampant in Vietnam due to the mental exhaustion. Men in combat are not always able to handle the stress and pressures of war. Excuse me.
Vietnam clearly left a mark on Bill, but his family considered him lucky because he made it out alive.
He's actually my hero.
LaShawn Gallman is Bill's son.
You know, not just because he's my father, I'm saying these things, but he was an amazing guy. So he got a job, he took the job at the fire department. And if you know anything about New York City history, during the 1970s, the Bronx was burning. He and, of course, his fellow firefighters were putting out fires regularly. So he was putting out fires, he was saving people, he was falling through floors, plenty of injuries, plenty of rescues. From there, he became a New York City fire marshal. He would investigate fires. And then fast forward to the 90s, he was able to become an environmental specialist.
What a life.
Yeah. All while trying to make sure that my sister and I had everything that we needed.
Bill, an avid sailor, and his wife Sandra retired to Martha's Vineyard in 2017. His wife was by his side when Bill was diagnosed with liver cancer this past December. But doctors on the island couldn't manage his pain, So he was flown from the Vineyard to Lahey Hospital and Medical Center, where he continued to receive his cancer treatments.
He just wanted to be there, and I made sure that he got there.
LaShawn lives in the Bronx, where Bill raised him. Once a week, LaShawn drove up to Falmouth, where he'd meet Bill and Sandra at the ferry. Then, they'd head to Burlington for Bill's weekly appointment at Lahey.
And that was something that he taught me. When people need you, you show up. And so that's what I did, because that's what he would do for me.
But Bill's pain was relentless and getting worse.
At that point, he had heard from the oncologist that unfortunately the disease was progressing to the point that was causing him all this pain, and that there wasn't likely going to be any more treatments for him.
He decided he wanted to go home.
The Bronx was where his son and daughter were, it's where all of his other family were, all of his friends were there. One of the major roadblocks then became, how do we get him there? And when somebody is going home or to a hospice facility from a hospital, usually always they're needing to be transported in an ambulance.
Insurance wouldn't cover the expensive 200-mile ambulance ride from Burlington to the hospice.
Because I was going to take him in my little Subaru and with the IV hanging up on the coat rack, we were getting down to New York.
That's where Dr. Beth Collins and the Hospice Comfort Care Fund came in.
There are more and more people who are needing hospice care for end-of-life care. Statistics show that 70% of people do not want to die in a hospital, they want to die at home. And the Women's Leadership Council incredibly took that on, and that's what's brought us to where we are now.
It was a grant from the Hospice Comfort Care Fund that made Bill's dying wish possible.
And when we told them that that was an option and that we were going to get him to the Bronx, get him home safely in an ambulance, his entire family just couldn't be more grateful. He actually had tears in his eyes. He could not believe that he was going to get to go in an ambulance and it wasn't going to be a burden for his family.
It means a lot for me personally. My sister, my father's wife, and all his friends. They get to come down, my aunt, my cousins, his sailing buddies, some of his firefighter friends. So it's just a very touching thing that we could be in touch with.
If you ask LaShawn and his family, they'll say you can't put a price tag on the time they were able to spend with Bill. Going forward, they not only have their memories of Bill, they have his own words, captured in his book to remember him by. A life lived in service to his country, his city, and his family.
I honestly believe that all living souls will have to give an account of the things that they've done in this life. My goal, therefore, is to be able to stand before my Creator one day and say, Lord, I did the best I could.
Wasn't that a powerful story? This is the kind of difference we are making, and we invite you to be a part of it. You can write a check today. There's a special envelope in your lunch bag just for this purpose. You can also make plans to come to next year's Ladies' Night Out on May 7th, a fun-filled evening that last year raised $158,000 for the fund. Or you can stop by our table in the lobby to buy a raffle ticket for a chance to win $4,000 of Mitchell Gold and Bob Williams merchandise plus $1,000 in design consultation. We will draw the winning ticket at Ladies' Night Out, and you do not need to be present to win. We are so grateful to Mitchell Gold and Bob Williams for being our raffle sponsor again this year. Now back to the reason we are all here today, to learn how to get a better night's sleep. I'm thrilled to introduce Dr. Paul Gross, a neurologist and founder and medical director of the Lahey Sleep Disorder Centers here in Burlington and at Lahey Medical Center, Peabody. Dr. Gross has been here for 37 years at Lahey, and 17 of those he was the chairman of the Department of Neurology. He's been a wonderful colleague to all of us here at Lahey, and we very appreciate him giving us this lecture today. think they have to set it up there.
I don't think it works.
I don't think it's on. Is the gentleman back there to turn this on?
If not, I'll use he could turn that on, but I'll use this. Does this work? To make sure. Hello? Oh, great. All right. Well, good morning and good afternoon, and thank you all for being here. It's an honor to be asked to give this lecture, and I appreciate you all coming out and hearing it. And that was a great cause that we just heard, and makes me want to help support it also. We're going to talk a little bit about sleep, and I am going to start with presenting a few cases to you, because as many of you may know, in medicine, this is how we ground ourselves and remind ourselves why we came to work that day. It's to help people with problems. So here's the first case. This is somebody I saw a few years ago, a 37-year-old naval officer who had had symptoms for about 20 years. He had excessive daytime sleepiness, and his day was filled with periods when he had a tremendous urge to go to sleep. It would happen when he was doing all sorts of activities. The episodes were relieved by a very brief 15 to 20-minute nap. Well, a lot of people are sleepy, but he had some additional symptoms. He had some weak spells, very unusual. So with laughter, surprise, losing his temper, he all of a sudden would get weak, particularly in his upper body, but sometimes would fall to the ground. And he had 5 or 10 of these spells per day. And to add to that, he had bedtime attacks. In his words, he said that when he goes to sleep, he goes into Never Never Land. He goes through periods where he can't move. He hallucinates, sees things, and he imagines that a cat is walking over him and he can't move. Okay, so just hold that for a moment. That's case number 1. Case number 2 is a 34-year-old cafeteria worker who's overweight, 350 pounds, and in his family, he's known as a very loud snorer. The kids can tell when he's asleep upstairs. They can hear the snoring through the walls. And in addition to that, he has severe excessive daytime sleepiness. His reason to come in to see me was because he was used to falling asleep and catching 2-second naps when he was driving on a straight road. But when he started going around corners, he would always wake up. But when he started napping on the corners, he said, maybe I have a problem. Okay, so he came in. Last case, number 3, is a 48-year-old woman. She used to sleep well, but now she has trouble starting sleep and maintaining sleep. Interestingly, although she has trouble falling asleep in her own bed, she can fall asleep easily on the couch when watching TV, or if she's traveling and is sleeping in a strange bed in a hotel room, she seems to fall asleep pretty well. She's a busy person, perhaps a little type A, and looking at her occupation, she's a full-time accountant. She has teenage children at home, and she recently went through a fairly traumatic year where she was the primary caregiver for her sick father, who then passed away with some difficulty, and it was very upsetting to her. She's tried various things, relaxation tapes, daily exercise, a few glasses of wine in the evening to try to relax her, but none of these things seem to help her at all. So we're going to look in a little more depth into some of these cases. But first, I just want to introduce you, see if we have a pointer here. This looks like a pointer. May not be. It's okay. Let me introduce you to the world of sleep medicine. Okay, so sleep medicine is a field that didn't even exist when I was in medical school, which you can surmise was a while ago. But the sleep medicine has sleep disorder centers and sleep labs. So a center is more comprehensive. It includes providers who specialize in sleep medicine. It includes neurologists, pulmonologists, psychiatrists, psychologists, etc., and also ear, nose, and throat doctors to help take care of some of the obstructions that may occur in the throat in sleep apnea. The lab in the center includes a sleep lab where we do testing either in the lab or at home. And we have the team consists of technologists, administrative people, advanced practitioners like nurse practitioners, and physicians. And together we work to try to help people with sleep problems. One of the interesting things from a medical point of view is that unlike some specialties, people can become a sleep physician from any branch of medicine. You just have to have completed training in one branch, like family medicine or neurology or psychiatry or ear, nose, and throat. And once you've completed that basic training, you can take a year or two fellowship and get board certified in sleep medicine. So when you see a sleep medicine physician, you're seeing somebody who might come from a very specific background and might have a certain slant on how they approach patients and on the diseases they're most comfortable with. So I thought it might be helpful to know that. The sleep field itself consists of four main problems. There's excessive sleepiness, people who are falling asleep all the time. Insomnia, which is probably the most common thing and probably why you came here today, right? People who have trouble falling asleep. Parasomnias, which is the medical word for strange things that happen at night, unexpected, unwanted things at night. And circadian rhythm problems when your sleep-wake cycle doesn't coincide with the sleep-wake cycle of the external world. So jet lag would be an example of that. So these are the four areas of sleep disorder that we concentrate on. So why are we sleepy? Why don't we start with that, because I'm going to talk a little bit about people who are too sleepy during the day. Okay, the most common reason why people in this country are not sleepy is that we don't devote enough time to sleep. Okay, the average American gets 7 hours of sleep a night. And we are biologically made to have about 8 hours of sleep, with two standard deviations between 7 and 9. So that means that 95% of people need between 7 and 9 hours of sleep a night, yet the country is getting 7 hours. So we are basically a sleep-deprived country. You'll come across people who say they only need 5 or 6 hours sleep a night, and there are occasional people who are like that, but most people who are trying to get by on 5 or 6 hours, or even 7, are sleep-deprived. So that's the most common thing. One of our physicians once came up to me and said, I don't understand why I'm so sleepy. And I knew him and his work habits. He was a busy surgeon. And I said, well, how much sleep do you get at night? He said, oh, I get 4 hours. I said, well, you know, that's not enough sleep. And he said, yes, but Dr. DeBakey, the famous heart surgeon, only gets 2. I said, all right, well, I guess you're not Dr. DeBakey. Okay. So aside from people who don't devote enough time to sleep, there are people who have a chemical imbalance in the brain. The brain isn't wired or programmed right, and it makes them too sleepy. And an example of that is a disease called narcolepsy, where there's a deficiency of a neurotransmitter, hypocretin, in the brain. The other, even more common reason for people to be sleeping during the day is that they think they're sleeping at night, but their sleep is actually very inefficient. The most common cause of that is sleep apnea, where people are intermittently stopping breathing at night. And some people have limb movements, even little tiny movements of the toes, which wake them up slightly at night. Not enough so that they're conscious, but enough so that it disturbs the flow of sleep. And then they're sleepy during the day. Now, I also see people who come in and say they're sleepy, but they're not really sleepy. They have fatigue or low energy. So I just want to make that distinction. So if you're tired, but you never have a pressure to fall asleep, it's probably something else that's going on. For example, depression or some other medical illness that can make you fatigued. So let's go back to our 37-year-old naval officer. So one thing I want you to note about him is that he has had symptoms, as I mentioned, for almost 20 years. So this is very common in narcolepsy, which is what this gentleman has. He goes through life undiagnosed. He's sleepy, he has weak spells, and he has these bedtime attacks. So narcolepsy occurs in 1 in 2,000 people. And that's a helpful number because that's the same incidence in the population as multiple sclerosis. So if you know 2 people who have multiple sclerosis, you know two people who have narcolepsy, they just don't know they have narcolepsy. So in other words, it's just as common, and it's very underdiagnosed. There are 4 features, and our patient had them all. Excessive sleepiness, which occurs in everybody, and then about half of patients have weak spells, which are called cataplexy, sleep paralysis, and hypnagogic hallucinations. And I'll tell you a little more about those. They also may never fall asleep inappropriately, and that's important. If you have a tremendous amount of drive, you may have irresistible urges to fall asleep, like some of you may be experiencing right now in a dark room after eating. You know, but you can fight those urges and stay awake. So you don't have to fall asleep inappropriately. They're often lousy sleepers at night. They're not sleepy during the day because they're poor sleepers at night, but it's part of the dysregulation in the brain of their sleep. The disease often starts in teens or early 20s, and they have a low level of this neurotransmitter, hypocretin, which is a neurotransmitter that helps to keep the brain and body from switching inappropriately from one state to another. So we can keep a steady state of wakefulness, but because these people are lacking hypocretin, all of a sudden their brain switches into sleep. Now, I'm going to show you a little bit about cataplexy, which is a very unusual symptom and basically unique to this syndrome. So cataplexy is a sudden reduction in muscle tone. And if you're talking to a patient with cataplexy, their speech becomes thick, their head drops, and their knees sag. And it happens in response to a joke or anger. So the person will usually lean on something, and they'll cover their mouth because they know their mouth is going to hang open, and it's embarrassing. This particular young lady who posted a YouTube video to share with us has very severe cataplexy. When people have these episodes, they're usually conscious, and they can tell you afterwards what happened. So I'm going to show you. Well, that didn't work. Okay. Now, there's laughter going on, and she starts to laugh, and she falls. I'm going to play that again for you because I want you to see something. So a couple of things. One is, and this sounds terrible, but it's true. In families with neurologic disorders where people do strange things, they're often the joke of the family, okay? Like I have a patient who has seizures every time she hears a bell ring. So when she was a little kid, her brothers would go around ringing bells, to watch her have a seizure. So this family thinks it's sort of funny. What happens? Someone tells a joke and she drops to the ground. The other thing I want you to notice about her is that she didn't just fall flat on her face. She crumbled down. And the falling in this cataplexy syndrome is called ragdoll falling. I don't know if you remember a ragdoll, which has no tone to it, but is just limp. So with that knowledge, I'm going to play it again, and you can see. And there she goes. And she'll stay there for a little bit and then she'll start to get up. So she'll have these.
No, I'm still filming.
She'll have these multiple. I gotta go there. She'll have these multiple times per day, and again. Again, precipitated by laughter, anger, and surprise. So somebody tells a joke to a group of friends, and there's a person who needs to sit down and cover their mouth. They may have cataplexy. The other thing that people with narcolepsy get is sleep paralysis. So the thing here is that up to 30% of normal people also have sleep paralysis. So, and I'll bet a bunch of people in the audience, whether you want to raise your hands or not, have this. So in the middle of the night, you wake, and you mentally awake, but physically you cannot move at all. And it's extremely frightening. You either can move again by just getting something in your body to move, like a finger, and then it releases you, or if you have a bed partner, they touch you, and then you move. And as I say, it's very frightening because you wonder whether you're ever going to move again. Has anybody ever had this? Yeah. So it's not that uncommon, but it's common in the narcolepsy syndrome. And then the last thing they get are hallucinations. And one time, I had a medical student working with me, and I had this hunch about what kind of hallucinations narcolepsy people get. So we looked at the medical records of the last 100 people who had come in for narcolepsy with hypnagogic hallucinations. And there was a theme in about a third of them, which is a furry animal that's on them or near their face. And it's going to come up towards their face if it isn't there already, and is going to harm them in some way. And they can't move, they're paralyzed. So this is obviously very, very scary. This is present in about a third to a half of people with narcolepsy syndrome. So anyway, that's a 1 in 2,000, a not uncommon thing. And if you know somebody who has it, you can now make the diagnosis and point it out to them. So here's our next case. Okay, this is our overweight cafeteria worker with very loud snoring and daytime sleepiness. So let's talk about this gentleman for a moment. This gentleman has sleep apnea, which is something you may be familiar with. Apnea means not breathing, so a person has episodes of not breathing in their sleep. So one thing to recognize is that apnea is a normal part of sleep. It's okay to stop breathing occasionally, and in fact it's completely normal to do it up to 4 times per hour. Okay, once every 15 minutes. But if it's more than that, it's abnormal, and at times it can be a serious condition. It gets worse with age, and hormones such as progesterone and testosterone are very important, and I'll get to that a little later. You might be familiar that we do tests for sleep apnea, and some of you may have had them. We do something called a polysomnogram, or all-night sleep test, in the sleep lab or sleep facility. We do home sleep tests, where we give you some equipment you can wire up and do at home. We do some sleep tests where we get some baseline information to see whether you have sleep apnea, and then apply a treatment, which is CPAP, or continuous positive airway pressure. Or we might do a test where we just apply the airway pressure. We know you have sleep apnea, and we want to know how much pressure is helpful to treat you. We grade apnea by how many times it occurs per hour. That's the key thing. Not how long they last, not necessarily how low the oxygen gets, but how many times they occur per hour. So severe apnea is 30 or more times per hour. That's once every 2 minutes. Okay, so that's pretty common. Mild apnea is under 15 times per hour. So the reason why this is important is there's a lot of medical literature that people in these two groups, if not treated, are at significant risk for heart attack and stroke. It's like having high blood pressure or high cholesterol and not treating it. So we know that people in these groups should be treated. There's a little controversy about this group, whether it's as important, but certainly the moderate and severe need to be treated. Now, this is a cutaway view, like you cut me in half and turn me to the side. This is a cutaway view of somebody's face. And there are a couple of things I want you to notice. First of all, the nostril isn't very big, but the nasal cavity is pretty big. When somebody sticks out their tongue, this is what you see, but the tongue is obviously huge. And all the air from let me get on this side, all the air from the nose and mouth has to go down a fairly narrow passageway to get to the lungs. And so this area can be blocked, and that is what gives people sleep apnea. Now I'm going to take that picture, and I'm going to turn it 90 degrees like this, as if the person is lying on their back, because I think it helps to make a point. So this is the same picture with now the nose up top, and this is the back of the throat. Now imagine you're lying down, going to sleep, and you start to relax your muscles. So the tongue relaxes. There are some muscles here in the back of the throat. This is the uvula, the little thing that hangs down the back of the throat. It all relaxes and blocks the airway. If it blocks it partially, you make vibrations in these tissues as you try to pass air through. We know that as snoring, okay? But if your bed partner is a loud snorer, and then they stop snoring, they're often not breathing, okay? So depending on your love or lack of, you may want to do something about this, okay? So alcohol makes this a lot worse. Alcohol is a muscle relaxant. So when you drink alcohol, it relaxes these muscles more. So anybody will tell you that if you share a bed with someone who's been to a party and they've had 3 or 4 drinks and they go to bed and they lie on their back, they may snore loudly, okay? And there is a generations-old memory that bed partners, usually wives, and I'll explain why in a minute, usually wives have, and the age-old treatment is right here. It's the elbow, right? You give an elbow, and the guy turns over on his side, and gravity is not making all this collapse down towards the back of the throat, and the snoring may get better. We have better treatments, but, you know, you can do that. Now, this is sort of a complicated slide. This is a page from a sleep test. But I show it to you to make a point. And that is that down here, all these lines are somebody breathing. So they're trying to breathe. They're moving their chest and their abdomen. These lines are air going out of the nose and mouth. So this is a person with bad apnea. And what happens is they take a few breaths and then they stop breathing. So there's no air going out of the nose or mouth here. And then they're making an effort with their chest and abdomen. So no snoring, no noise, chest and abdomen moving, but no air coming out of the nose or mouth. This is the blood oxygen. It goes way down. I can't read that, but 90-some% of the red blood cells have oxygen in them. Now only 61% have oxygen. That's a tough road for the heart and the blood vessels. Causes a lot of inflammation and irritation. So this happened. The other thing I want you to notice is this isn't happening once. It's happening repetitively through the night, and most of the night is spent not breathing, and just a little bit is spent breathing. So this is what someone with severe sleep apnea looks like. And here's a picture. See, that's not good. The snoring went away. There's no breathing going on. And then starts up again. There you go. So this is what we're trying to treat. Now, risk. Who gets sleep apnea? So males get sleep apnea more commonly than females, particularly younger males. And here's the reason. It turns out that progesterone, a female hormone, is a respiratory stimulant. If you give somebody progesterone, they will breathe harder and they will hold the back of the throat open a little better. Women make progesterone until menopause and then stop making it. So that's why a 30-year-old woman and a 30-year-old man with the same anatomy in the back of the throat will have different likelihoods of having sleep apnea. The woman is protected by her progesterone. But after she goes through menopause, if she's not taking any hormone replacement, then she loses that protection and she's more likely to come out with sleep apnea. Testosterone makes breathing worse. So, I go to the gym and the guys who are next to me, they all have low T, right? Their testosterone is low and they're trying to beef it up. May not be the only problem, but anyway, so they take testosterone injections, but you have to watch out when you give people testosterone injections because it may actually produce sleep apnea. As you get older, apnea gets worse. It can run in families. There are certain diseases like hypothyroidism that give people large tongues that can do it. Big tonsils and a narrow throat will make it tighter in there. Obesity will make it tighter in there. Alcohol. I tell my patients, do your drinking in the morning, okay? We don't want it in your system when you're going to sleep, okay? And if you have a nasal obstruction, you have to suck in harder when you breathe, and it creates negative pressure in the back of the throat and collapses it. But the main treatment for sleep apnea is CPAP, continuous positive airway pressure. Basically, it's just an air compressor, like you use to blow up your tires, okay? Except it's a lot more sophisticated. And it blows air into your nose and throat, and it acts as a splint and holds the throat open so it doesn't collapse. And this is the best treatment for sleep apnea. There are other things we can talk about at this time, but this works for just about everybody if they can tolerate it. Some people can't tolerate it, and we can talk about that also. Okay, so we talked about excessive sleepiness. I'm going to talk to you about a parasomnia. Now, as you recall, parasomnias are unwanted or abnormal behavior at night, like a night terror that little kids get. They sit up and scream, panic attacks or anxiety attacks during dreams. But there's one particular one that it's helpful for people to recognize, which is called REM sleep behavior disorder. So this is a really interesting condition, and I'll just go through the explanation of it. In REM sleep stands for rapid eye movement sleep. It's one of the stages of sleep. You spend about 20 or 25% of the night in REM sleep. In REM sleep, you're paralyzed. You don't know this because you're asleep, but presumably we're made that way so if you dream you're running, you don't actually run. There are people who have lost this ability to be paralyzed in REM sleep. So they dream they're running or punching or kicking, and they actually do it. Obviously injurious to themselves and to a bed partner, and people may fall out of bed. It's much more common in men. Patients may often be unaware they have it, and it can be due to some medications, such as antidepressants can sometimes bring it out, but it turns out that this condition, which we've known about now for about 30 years, is the first stage of a degenerative condition in the brain. So the brain starts to age, and you're at risk for developing some neurologic illnesses, most notably Parkinson's disease. It may not occur for 20 years, but it's the first stage that of that condition. So I'm going to show you a video of somebody who's having an episode of REM behavior disorder. I'm sorry, I don't know if we can turn off those lights, but this is all done with an infrared camera and light at night. So he's in a dream, thank you, he's in a dream now. And he's dreaming about fighting somebody. So he's supposed to be paralyzed, and he's moving. Now, we can turn these on again. So now what's interesting about this fellow is, this is the first patient I saw with this condition. And he didn't come to see me for a sleep problem. He came to see me as a neurologist because he couldn't walk right. He was in his 70s. He was a nuclear physicist working, had been doing very well until about a month previously when he felt off mentally and he couldn't walk right. So, like any good neurologist, I ordered a scan, and his scan showed a layer of blood over the surface. This is dark area over the surface of the brain. So that was kind of interesting. So I said to the couple, how did that happen? And the guy shrugged his shoulders, and the wife said, I know. You should see him at night. He's banging his head against the headboard, and he's wild during the night. So putting two and two together, this fellow had REM behavior disorder. He got better from this blood clot. It reabsorbed, and we were able to treat his REM behavior disorder, so it had a happy ending. Okay, the last thing we're going to talk about is trouble sleeping, insomnia, which is, probably the most common thing. So let's talk about different types of insomnia. So, everybody, I think, has experienced short-term insomnia. You have a test tomorrow and you're anxious about it and you can't sleep. That's normal. Okay. It's common to have insomnia in menopause for many reasons. One of them is hot flashes, which are the inability of the brain to, we like to think in neurology everything comes from the brain, right? So it's the inability of the brain to control temperature. So all of a sudden the temperature regulatory system of the brain doesn't work right. And that is it turns out that's an estrogen function. Now, why don't men get it? You only wish, right, that men would get it. Why don't men get it? Because it turns out that you have to have been exposed to estrogen for a long time, and then if you take away the estrogen, that's when this comes on. And if you replace the estrogen, this tends to go away. So obviously that can disturb sleep at night. As you get into middle age, it's not just the hormone changes, but, various aches and pains, hip problems, shoulder problems, etc., that bother people. Bed partner may have restless sleep that may be disturbing them. Midlife depression, anxiety. So often it's not pure. There's often a combination of things that occur in menopause that can disturb sleep. Then the last two categories, there are people who were just never good sleepers. I mean, their family story is they didn't sleep well as a 3-month-old, and they don't sleep well as a 50-year-old. They just never really slept well. There's something differently wired in their brain. And then maybe one of the most common causes of insomnia is a long-term psychophysiologic insomnia. Basically, That's a learned behavior. You've gotten into a situation where your body has gotten used to not sleeping, and it now becomes a habit, particularly not sleeping in your own bed, and you have to break that habit. So this psychophysiologic insomnia is conditioned poor sleep behavior. The poor sleep habits become part of the routine behavior. So in the case I presented earlier of the woman who was having trouble sleeping, you remember that she helped to take care of her elderly father who then passed away. So that was a very traumatic event, and it's often something traumatic, major surgery, a traumatic emotional event that sets people off to poor sleeping, and then once they become used to sleeping poorly, they have trouble getting back into a normal routine. And one of the things that happens to them is the whole situation of their bedroom and their bed almost induces anxiety or panic, because they know when they go into bed they're going to have trouble sleeping and they don't want to have to face that again. And so sometimes, paradoxically, these people do very well in a hotel room because it's a completely different environment, or they fall asleep, watching the latest HBO show or something else, because they're not supposed to be going to sleep then, so the pressure is not on. The treatment is good sleep hygiene, which we'll talk about, and you probably know all about. Something called cognitive behavioral therapy, which is basically training the brain to get you to sleep normally again, as well as looking at other things psychologically that might be interfering with your sleep. And of course, being doctors, we have drugs that can get people to sleep. So I want to talk a little about cognitive behavioral therapy, and our cognitive behavioral therapist is sitting over there in the front, so she's going to correct me if I don't do this right. So one of the things we do is to educate patients about sleep needs, about sleep habits, good sleep hygiene, etc. If you're anxious or depressed, and that's keeping you from sleeping, obviously that needs to be addressed either through therapy or medication or something. Relaxation therapy can help some people. Establishment of a stable sleep and wake times, very important to get into routine habits of when you go to sleep and when you wake up. A very interesting therapy for insomnia is sleep restriction therapy. So I'll give you an example of sleep restriction therapy. A patient comes into the office and says, "Oh, it's terrible, doctor. I go to bed at 10 o'clock, I don't fall asleep till midnight, and then I'm up at 4, and I lie in bed for a few hours." So the doctor says, "Oh, you're only sleeping 4 hours." And they go, "That's right." And the doctor says, "Okay, this is what I'd like you to do. I want you to go into bed at 1 a.m., and I want you to get out of bed at 5 a.m. And that's the only time you can spend in bed." And the patient says, "But that's only 4 hours." And you say, "Yes, but that's all you're getting now." So anyway, the idea is to train the patient to go into bed, go to sleep, stay asleep, and wake up. And of course, they'll be sleep deprived, and hopefully be able to sleep solidly during that 4-hour period. And then, sort of like training a baby to sleep, then you expand the time, 15 minutes at the beginning, 15 minutes at the end, until you can get a good 7 or 8 hours sleep. So that's a way to retrain somebody to sleep without having to use medications. Good sleep hygiene is important. Use the bed only for sleep and sex. We used to say use the bed only for sleep, and everybody's going, Yeah, so we say, okay, use the bed only for sleep and sex, and, no reading, TV watching, eating, or other things. And then you guys know this. I mean, good sleep hygiene. I think we've already talked about all these things. Exercise, vigorous exercise at bedtime can stir you up, and too much light exposure, alcohol, caffeine. Let me just say I think I'm getting the hook here, but just say one thing about alcohol. Alcohol will help to get you to sleep, but it often disturbs sleep in the middle of the night, often like a mini withdrawal. So you'll fall asleep, but you wake up at 2 a.m. sort of a little agitated, and that's not, it might be worth it, I don't know, but it's not really good. Okay, and then there's medication, melatonin, and some other medications we can talk about if there's time. And the last thing I'm going to say is worry. Okay, worry keeps people from going to sleep. This is going to sound really funny, but it works, okay? We all worry, okay? So why don't you decide you're going to worry from 7 to 7:30 every night? Okay? Go through your head with all the things that are going to bother you and get it off your chest. Okay? And then when you go to sleep, you'll have done it. And then the last thing is the big circle here is everything that bothers you. The smaller circle within it is everything you can do anything about. A lot of people spend all their energy here. It's useless, right? These are the things you can't do anything about. Spend your energy here. Okay. And that may help you a little bit. And that's all I have to say other than that.
Thank you, Dr. Gross. Can everybody hear me? My name is Liz Sacco, and I am the co-chair with Dr. D'Eduardo for the Education Committee. And I'm going to open it up to some questions and answers. We are a little bit strict on time with Q&A, so you're available to ask Dr. Gross some questions after. But we'll go ahead and open it now to any questions you may have.
You want to just look at drugs? Sure. Yep.
Thank you, Dr. Gross. I was just wondering how Fitbits work in monitoring sleep stages and how dependable that is.
I don't find it that helpful. I mean, it's interesting to know, of course, but it's not vitally important what stage of sleep you're in. And if you start getting obsessed with what your Fitbit says, it can just be one more source of anxiety. So it's something people do, but it's not something I recommend necessarily. We had a question about medication, so I'll just briefly say melatonin can help some people sleep. 3 milligrams, and you can take up to 6 a night, gradually increasing. Gabapentin is a medicine commonly used for pain. It has a side effect of making you sleepy. We use it to our advantage by giving it to people at bedtime. It helps them go to sleep. Non-addictive. Safe medicine. Trazodone, a lot of the psychiatrists use this. It helps to relax people. If you have to use a sleeping pill, there are various sleeping pills available, and I could list a whole bunch of them. My practice, if I have to give a sleeping pill, is to say, okay, this is what we're going to do. You're going to take a sleeping pill every Sunday, Tuesday, and Thursday night. I don't care what you think. Just do it those nights and don't do it other nights. Because sometimes people will go, oh my God, should I take a sleeping pill? Should I not take a sleeping pill? And you lie in bed for 3 hours. Just do it every Sunday, Tuesday, and Thursday. So here's what happens. Sunday night, you get a good night's sleep. Monday night, you go, I'm having trouble sleeping, but I got a good night's sleep last night, and I'm going to get a good night's sleep. So it kind of takes the edge off and takes the anxiety off, and then you don't get addicted to it. Okay, enough about medications.
Thank you for the presentation. It was really nice. I have a question about melatonin.
Yes.
Many people say that it is a plant-based medication and it has no side effect. In your opinion, what are the side effects?
I rarely, if ever, heard patients describe side effects that I can say are definitely from the melatonin. You know, if you give people a placebo, 10% of people will get side effects. So I'm not sure I can say that anything definitely happens. I mean, okay, so any medicine, any substance can make some people nauseous. That's possible. And any substance can cause an allergic reaction. That's possible. But I'm not seeing a lot of that with the melatonin. The biggest comment I get about melatonin is that it didn't, when it doesn't work, is that it didn't work. That's the comment that I get from people. I've not seen that. No.
Yes, my son-in-law used CBD oil. What's your opinion of that?
Oh my God. Okay, I don't know if you saw the New York Times Sunday magazine had a cover about a month ago, and it said CBD oil, and then there was a big circle that listed the 120 diseases that CBD oil is supposed to help. Okay, so I don't know what to say. I'm not aware of any good scientific studies that tell me that CBD oil is helpful for sleep. It seems to be pretty harmless. So for those who don't know, CBD oil is the non-hallucinogenic part of the marijuana plant. So it is safe to take. It's not addictive. You could try it, but I can't say that scientifically anything on it is proven. But on the other hand, if he takes it and he goes to sleep, God bless him. I mean, that's great. Yeah. Ooh, where is that? Yes, I just can't hear the question. A little. Okay. The only treatments I really know of that are successful, aside from stopping a medication that might be precipitating it, the only treatments are with medication. So the standard medication that we've used for years and years is clonazepam, which has the brand name Klonopin, and which is in the Valium family and is potentially addictive. In the last couple of years, there have been reports of melatonin, again 3 to 18 milligrams, being used for RBD, and it does seem to help a lot of people. So I always start with melatonin, and only if that's not successful do I go to the clonazepam. You're welcome. 3 to 18. So you buy over the counter, you can get 3 milligram melatonin, and then you can take up to 6 of them at night, if slowly increasing if you need it. You're welcome. Yes. No, melatonin is not addictive. As far as I know, it's okay to take it every night. Yeah. Yes, sir. No. In other words, in terms of making you more likely to have a dementia, no. Although there is some evidence that if you don't sleep well, I don't mean to cause anxiety in people, but if you don't sleep well, you might be a little more likely to develop dementia, but it's a chicken and egg thing. It may be that the sleep function in the brain is disrupted because you were going to get Alzheimer's anyway. But these medicines, if used judiciously, are safe. The problem is that these on the bottom, these 3, are at least possibly addictive, if not physically addictive, then psychologically addictive. So we try to steer away from them. But on the other hand, if someone's, they're supposed to help people, and if someone's life is really miserable and nothing else works, I think they're a reasonable option.
Okay, I think for the sake of time, we just have one more question.
So I have a question as I'm listening to all this, and I have every single thing. It's
you
been...
must be a medical student.
Exactly. No, nurse. Right. But truly, it can have 5 nights of complete awake. I've tried Lunesta, I tried Ambien, and they work. Only problem with the Ambien is I drove and didn't know it. I have tried, you name it. So I guess my question is, as I try to self-diagnose, would you recommend just maybe coming to see you?
We have several sleep specialists at the clinic, and yes, absolutely. I think if you've made a good effort, and then I think it's probably worth having someone take a look at you. Yeah. Yeah.
Really quick, amitriptyline, aka Eladil, is that good for sleep disorder?
Yes, amitriptyline has a side effect of making people sleepy, and it's good. It can make prostate problems worse, so you just have to be careful. Thank you all. Yeah.
Thank you again, Dr. Gross. Well, I hope that you all enjoyed the presentation. And we'd like to, can you guys hear me? That's okay. Thank you again to our sponsor, Northbridge Insurance Agency. And if everybody who's still here could quickly look into your bags, and each one of the bags, what Dr. D'Eduardo had touched on is what you will find is basically it's a complimentary membership to Mitchell Gold and Bob Williams, which is $100 value. It's free to you, and you're able to take advantage of all the discounts. So if anybody's in the shopping for furniture, please take advantage of what you'll find. And let me just show you. It looks like this, but if this doesn't look familiar, there's a copy of it. All right, thank you.
They're not listening. They're walking out. No one's listening now.
right, we'll see you later.